Thank you, Dr. Neeraj. So good evening to all of you. On behalf of the MPAI, that's the Molecular Pathologists Association of India, it is my pleasure to welcome the guest of honor, Dr. Nirmala Padmanabhan, who is a surgical pathologist from Sydney. I also welcome everyone who is present online for this webinar. Now to introduce Dr. Nirmala, she is an associate professor, Dr. Nirmala Padmanabhan, and a surgical pathologist with a keen interest and expertise in breast diseases. She's the director of the Westmead Breast Cancer Institute in Sydney, and also the director of the Breast Screen Program for Sydney West, and the lead pathologist for this program. Besides covering Sydney, along with the University of Western Sydney, Professor Padmanabhan is currently a specialist breast pathologist of Douglas Hanley Moyer Pathology. So Dr. Padmanabhan is the principal investigator of a number of grant-funded projects and is a past executive committee member of the Australian Breast Cancer Tumor Bank. She is a member of NBOCC Sentinel Node Biopsy Subgroup and was involved in the development of recommendations for use of sentinel node biopsy in breast cancer. Her efforts are in improving the quality of breast cancer pathology and HER2 testing in several countries across the Asia-Pacific region. She sits on the executive committees for the Australasian Society for Breast Diseases and is a national clinical board advisory member for Breast Screen Australia. Her primary research interests are in HER2 testing, prognostic markers in ER-positive breast cancer, and borderline lesions of the breast. So with these words, I invite Dr. Padmanabhan to deliver her talk on evolving landscape of HER2 diagnostics. Dr. Padmanabhan.
Thank you. I'm just going to share my screen.
And anyone who wants to ask questions, there's a chat box. You may put in your questions. And Dr. Neeraj will collate them and will forward them to the speaker.
Thank you very much. Thank you very much, Dr. Mukherjee, for that very kind lengthy introduction. I think I might have met many of you already last year, and I would have loved to have been there in person with you this time. But unfortunately, this time of year is very busy for us, so I was not able to get away. Thank you so much for this opportunity, AstraZeneca, and I really would like to commend you on involving the pathologists so much in this discussion. We have become a really important part of this new world of HER2 diagnostics and how things are really changing so much in this landscape. And it's very important for pathologists to be involved in these discussions. So I really commend AstraZeneca for promoting this and promoting the role of the pathologists in all of this. So I'm going to talk to you today about how things have changed with HER2 testing, which has been around for a very long time now, a couple of decades, but things lately have begun to shift and the landscape is really becoming quite diverse, and the involvement of the pathologist in all of this is very crucial. So I think this is a very timely talk to give, given the changes that are happening in this space. So just seeing how to keep my slides forward. I have a technical issue. Sorry, just 1 second.
Ma'am, just click on the slides once.
I can see there. Yes, sorry, got it. Okay, these are my disclosures. Okay, so worldwide, in Australia, we use dual testing of HER2. Worldwide, the most widely used method of testing for HER2 is using immunohistochemistry. And, it's widely practiced. It's a very cheap technique that's used in all laboratories, which is automated. You can store the materials long-term, and the morphology is available in the section to view at the same time as the immunohistochemical stains. But we all know as pathologists, there are issues with immunohistochemistry, that it is susceptible to numerous variations in the testing protocol all along the whole testing phase of the tumor tissue. There are numerous areas where we can experience variation. And of course, interpretation is subjective and semi-quantitative. And these are some of the issues that have been marred HER2 testing across the world. But it is very important, and immunohistochemistry has been the mainstay, the main way that we are identifying, appropriate treatment pathways for breast cancer patients. So it is really hasn't changed things. It's been around for many decades, and things haven't really changed very much from there. We still need to do basic immunohistochemical testing every day for every single patient. And this provides us with really important prognostic and predictive information that help us to assign patients to the appropriate treatment pathways. So these are really, immunohistochemistry is here to stay, and something that we will continue to work with in time to come. HER2, of course, as we've been discussing, is primarily tested with immunohistochemistry, looking for membranous staining. And what we're looking for is the target receptors on the cell surface. And we know now that there are many different mechanisms by which we can target that HER2 antibody on the surface of the tumor cell membrane. Once we have ligand binding to the HER2 and family receptors, we get heterodimerization of the HER2 receptor, which then triggers a downstream receptor kinase phosphorylation, and that triggers multiple signaling pathways that lead to gene transcription, tumor cell survival, proliferation, invasion, and metastases. We're very familiar with all of these, and HER2 is one of those receptors that can be targeted, and we've been doing that for at least the last 2 decades now. And how have we been testing for HER2? Well, as I mentioned, immunohistochemistry is the mainstay of testing worldwide. But in Australia, we do things a little bit differently. We actually need to demonstrate ISH positivity using any of the ISH methods before you can have eligibility for HER2, for anti-HER2 therapies. And this is because we felt that in Australia, immunohistochemistry there was a lot of variation, and the membrane staining is very much affected by pre-analytical problems, analytical problems that ISH testing isn't subject to. And DNA is much more robust than protein, and therefore we find that when we test even samples that are somewhat degraded, we get a better result with ISH. So we found in Australia that ISH testing was going to be our first line testing. But now we use a dual testing methodology using both immunohistochemistry as well as an ISH test. And worldwide, I think FISH has stood out as sort of the gold standard in terms of ISH tests. But there are other ISH tests available. So KISH, which is chromogenic in situ hybridization, CISH testing, which is silver with a single probe. And then we also have the dual CISH testing, which has really stood out as probably the best method for testing and what is recommended by our colleges here in Australasia, that we use a dual CISH stain rather than even FISH. And I'll go through the reasons why we are doing that here in Australia. So whilst we've always considered FISH, and most of the international trials that have looked at HER2 have also used FISH as the gold standard for testing for HER2 positivity. And it's used worldwide in the 2+ space, whereas in Australia, we test all 2+ and 3+ with ISH testing. And we've got to demonstrate ISH testing for patients to be able to access any of those anti-HER2 therapies through our pharmaceutical benefit scheme. We choose in Australia to do DISH testing for a number of reasons. There are a few disadvantages with FISH testing. First of all, it uses a fluorescence mechanism, so you've got to have dark field microscopy and a setup for that. Specimen preparation is more complex and it's not readily automated. Whereas DISH tests, there are like on the Ventana system, for example, you can easily automate these tests and do them overnight in a very easy manner. And there are pre-prepared kits using Inform assay, for example, that we use here in Australia. So we prefer to use the ISH tests that use the dual probe and light microscopy rather than the dark field microscopy. One of the disadvantages of FISH is that the histologic features are not readily discernible because you're using dark field microscopy. Plus, you have to go to very high power using oil immersion in order to visualize the signals. The signals themselves, of course, degrade rapidly. And this has implications if you want to get a second opinion and the person isn't available, immediately, or you want to send it away. And also for archiving, you can't do that with FISH tests because those signals tend to degrade. One of the advantages, however, is that you get a very high power view of the signal. So I've got a couple of pictures here on the left side of your screen, I hope you can see. And what you can see there is that the magnification of the HER2 signals on fish is very easily visualized using the fish test, not so easily recognized using the dish test because it's at a lower power. But we use the dish test as our routine test. So the way that I work in practice is if I have a case, using the dish, if I have an equivocal result where I'm not really getting a good look at the signals, and I've got a consistently equivocal result, I will send it off for fish testing, which is really only amounts to a very small handful of cases. So I use that as my go-to for really difficult, complex cases that I'm not 100% sure of. And that is because you can really enumerate the signal probes, especially in that area where you have low levels of amplification or co-amplification. You can visualize the signals a lot better on the fish. But this really is needed for a very small number of cases, a handful of cases per year, I would say. And my go-to, my routine test, and what is recommended by our college is to use the dual in situ hybridization test using the silver probe and the red probe for chromosome 17, simply because of the convenience and the ability to do it in your routine laboratory tests and do it, alongside your routine tests for any breast cancer that comes through your door. So HER2 targeted therapies have really developed over the last 2 decades, and we've seen newer and newer mechanisms for attacking the HER2 receptor and using different methodologies in order to really target those tumor cells. And we've really seen this as an evolution that is continuing to develop. And in the last 5 years or so, we've really seen some new and exciting therapies that have come into this space. And that's what we're here to talk about today. In line with the newer drugs that have come along, there have been developments in the way we look at HER2 or examine for HER2 in terms of the ASCO-CAP guidelines worldwide. And these have changed over the years. As you know, that we've had changes in thresholds in terms of the immunohistochemical staining going from 10 to 30%. And there have been other updates in terms of equivocal results and how to report these. That I won't go through in a lot of detail because I'm sure you're all familiar with this now. In Australia, these are our Australasian guidelines that have come out in 2018. Basically, nowadays, we have to do dual testing. So we do immunohistochemistry as first line. If it turns out to be a 0 or a 1+, we call these negative. And we'll talk more about that. That's really what we're here to talk about today. But the 2+ and the 3+ will always go on to have an in situ hybridization test. And as you know, those that are in situ hybridization positive and 2+ are considered positive and eligible for therapies, anti-HER2 therapies, and same for the 3+. But we have to demonstrate that in situ hybridization positivity with the 3+ as well as the 2+ here in Australia for eligibility for treatment. Okay. So anti-HER2 therapies have come a very long way from the days of trastuzumab, where we had the drug binding to the extracellular domain of the HER2 receptor, which then produces a signal transduction and a cascade of events that lead to cell proliferation, metastases, etc., etc. Pertuzumab, a newer drug, actually prevents the dimerization of HER2 receptor with HER1 and HER3 or other HER2 copies, which is needed for that triggering of that downstream cascade of events. And pertuzumab blocks that dimerization. Smaller molecules such as lapatinib and neratinib are tyrosine kinase inhibitors, and these work on preventing that downstream cascade from taking place in the first place. Even once the receptors are dimerized and been activated, it prevents the downstream processes. And TDM1, which is one of the newer drugs, actually targets HER2 and internalizes the receptor. And this is bound to an anti-microtubule agent, which is a really powerful anti-proliferative agent, and it allows for intracellular drug delivery. So the drug is really targets the tumor cells themselves, and it's internalized for really targeted drug delivery in these patients. So that brings us to to TDXD. I won't say the whole name. I'm getting it's late in the night here, so please forgive some of my mispronunciations. I've skipped a slide. So very recently and I'm sure you've already heard all of these results from the Destiny-04 breast trial, which really looked at the effectiveness of TDXD in the HER2 low space, which is immunohistochemical staining for 1+ or 2+ and negative on ISH. And once these patients tended to respond really well to a new drug that has just been released on the market. So this drug, trastuzumab deruxtecan, is an HER2-directed antibody drug conjugate. So it's similar mechanism to the TDM1 that I mentioned in terms of being internalized by the tumor cells. And it is coupled with a topoisomerase 1 inhibitor payload. And this drug is internalized, and we've seen remarkable improvements in progression-free survival and overall survival in patients with HER2-low breast cancer using the definitions that I mentioned, so 1+ or 2+ without amplification. And even though these patients were heavily pretreated, they still had remarkable improvements in progression-free survival. And this has been really something that has revolutionized with the way we're looking at HER2-low breast cancers. So you can see in the cartoon depiction here that HER2-low breast cancer are targeted by this antibody, which is bound to the topoisomerase 1 inhibitor, which is then internalized. So why do we have this highly effective therapy? Partly the reason is because once the drug is internalized and the cytotoxic agent is released, the cell itself is killed, and then the drug can actually escape through the cell membrane and have what we call a bystander effect, so that it attacks all the surrounding cells that may not express HER2 to have a cytotoxic effect, even on those cells that do not express HER2 at all. And interestingly, these antibody drug conjugates target cell surface antigens, and they allow these cells to be like a homing signal, and they produce a precise delivery of these drugs right into the tumor microenvironment. And even low levels of HER2 1+ as well as 2+ negative ISHs are impacted by this antibody drug conjugate. And you can see in this waterfall plot here that the 2+, and I would have intuitively thought that the 2+, because they've got a larger amount of receptor on the surface, might have had a greater effect. But you can see that the 1+, as well as the 2+, actually both have equal efficacy of the drug, regardless of the fact that the 1+ have less cell surface expression of HER2. So that's really remarkable. And it talks to, I guess, the mechanism of action, which is that it is a diffusible cytotoxic moiety, meaning that it can diffuse out of the cell that it targets once the cell is killed, to have this bystander killing effect of the surrounding tumor cells that do not express HER2. So it targets even heterogeneous tumors can be impacted by this mechanism. So that's a pretty remarkable finding that's really sort of taken the world by storm in the last few years. And this is really important because a significant proportion of breast cancers are HER2 low. And many of these patients, especially as they've had lots of lines of metastatic therapies prior to TDXD, they don't have a lot of options left. So this is a remarkable, especially for triple-negative breast cancers, and about 34%, a third of all triple-negative breast cancers, do have this phenotype of being HER2 low. So this represents a potential for really expanded HER2-directed therapies, an expanded armamentarium for these patients in particular, who may not have had a lot of options to date. So turning back to the ASCO-CAP guidelines that I'm sure that you're all familiar with, the HER2 low group is constituted in this case by the 1+ positive, or those that are called 2+ positive but are negative on ISH. I'll come back to the HER2 zero because that's where we've got some developments most recently. But the HER2 low groups are the ones that we're talking about are in the middle here, the two middle groups, the HER2 2+ negative on ISH and 1+ on IHC. So this really has changed the way that we think about HER2 testing. We've gone from our long-held views about positive and negative to really having something that's a lot more granular. And I'm going to talk about the second and the third and the second, third, and fourth items here as we go through. So we're going to talk about HER2 ultra low later on, but for the moment, we just focus on the HER2 low, which is that 1+ and the 2+ with the negative ISH group. So in the very beginning, when we started doing HER2 testing, and this was back in the early 2000s, this was data collected from a colleague in the UK from their quality assurance program. And I know I'm harking back to very old data here, but I just wanted to highlight some of the problems with immunohistochemistry. You can see here that the positivity range is from 9 to 35%. So that means some labs are getting it right and some labs are getting it wrong. So there's lots of false positives and false negatives happening here because we expect the HER2 positivity rate to be around 15%. And this is when we first, started doing HER2 testing, and highlights some of the issues that we have with getting things right with immunohistochemistry and really optimizing that stain. In the Australian testing program, we found that about over 80% of cases retested by immunohistochemistry because we had this unique opportunity because we've first-line tested cases with ISH. So we could go back and then use immunohistochemistry on these cases to see how well they aligned with the ISH testing. And you'll see that actually, the 3+, only 82.6% of them correlated with a 3+. So about 20% of cases are being missed on immunohistochemistry. And, this looks a bit sad, but I can confirm and want to assure you that we really have improved things since then. But this is several decades ago, a couple of decades ago anyway. So why would we have this discordance between 3+ and ISH amplification? Could it be a real tumor type or polysomy? Is it possible to have the protein overexpressed in the absence of gene amplification? If that's the case, these are very rare cases. I believe that there are some very rare cases where you can have protein overexpression through other mechanisms without actually having gene amplifications. But there's no data really to support this mechanism. And if it does occur, it's a very rare phenomenon, of course. So the majority of cases must be due to testing inaccuracy, procedural failures, problems for us as pathologists interpreting things as 3+ or 2+. And immunohistochemistry is subjective, we all know that. Plus heterogeneity, perhaps part of the reason we get some of these cases wrong is due to tumoral heterogeneity. Well, it's hardly surprising that we have these discrepancies because there are multiple sources of variation for immunohistochemistry in the pre-analytic space, in the analytic space, and the post-analytic space. And I want to talk through some of these because I think this is really important in terms of getting it right with the HER2 low group, which is now becoming really important to recognize. Standardization, of course, we know this of practice, quality assurance programs, and automation, which is now, routine in most laboratories, have the potential to have significant impact. So let's talk through some of the pre-analytic issues, and in particular, some of those that impact the HER2 low breast cancers. So fixation is one of the major issues, and overfixation and underfixation can produce very poor results. And you can see here, when you have overfixation, you can have loss of immunogenicity. And if you have underfixation, you can have cytoplasmic staining and lots of artifacts. So getting the time to fixation right is important. And we in Australia mandate that we put on our reports the time that the specimen has been fixed to ensure that the specimen is put into formalin as soon as we receive it. We need to have optimal fixation because formalin preserves those proteins and organelles that we need for it to bind to the immunohistochemical assay. And we need that formalin to penetrate the tissues very rapidly to ensure that those cross-links are formed between the tissues and the proteins to prevent it from degrading. And in I don't need to explain this to us. We're all pathologists here. We understand this. This slide's left in there really for the clinical people, but we understand the importance of optimal fixation to ensure that we can have good antigen antibody reactions so that we can visualize the stains on immunohistochemistry. So overfixation forms excessive crosslinks, can be reversed with antigen retrieval, but you still do have the potential for, with over retrieval, for getting false positive results. So you really need to be very careful. And under fixation, of course, the crosslinks take a long time to actually form. And if the duration of fixation is too short, then the crosslinks that you get between the amino acids and the proteins in the tissue will begin to break down before the tissue is properly fixed. So you can get inconsistent staining, heterogeneity, and difficulties in interpretation. So getting that fixation right is really a significant step in ensuring we get an accurate result with immunohistochemistry. The cold ischemic time, so that's the time it takes from the time the tissue is removed from the patient and placed into formalin. That again is very impactful, and I won't go through this in detail because we as pathologists know the importance of fixation. So next is archival samples. So this is important when we're thinking about TDXD and testing for the HER2 low groups, because in many cases, you can actually go back and test archival samples and find one sample that is positive to make the patient eligible for this therapy. So you can test the primary tumor, you can test metastatic samples, you can test archival samples to find that one positive sample. But one of the issues is that we must make sure when we do this that we take the sections fresh from the paraffin block. So you can see here that when you try to test for HER2 on a section that's been taken 6 months previously, you don't get the positivity. Whereas if you take a fresh cut section off the block and then test that, you're more likely to get positivity. So that's an important lesson for us to remember, because archival samples, are maybe useful for testing for HER2 low patients. So just to recap and remind ourselves, what of the important issues in the pre-analytic space is core biopsies preferred to excision specimens simply because of the better fixation in the smaller sample. We have to ensure that the time to fixation is less than an hour. There's optimal duration of fixation of 6 to 72 hours, depending on the tumor size, knowing that formalin penetrates the tissue at about 0.5 millimeter per hour. And we need adequate volumes of neutral buffered formalin and fresh cut sections taken from the paraffin block, 5 to 10 microns in thickness, no older than 6 weeks. The section should be no older than 6 weeks. And decalcification is an issue because a lot of breast cancer patients do have bony metastases, but these have not been used in the clinical trials simply because the decalcification processes may produce an unreliable result. Analytical conditions. So this is ensuring that the optimal conditions are met for the assay itself. The first thing to consider is what antibody do we use? In Australia, vast majority of laboratories use the Hercept test. So it's a rabbit monoclonal antibodies. So 4B5, either of them, either the Roche diagnostics or the DACO agents are mostly used in Australia. Rabbit monoclonal antibodies are much more specific for the HER2 assay. The others may not have as good specificity, and also the scoring may be a little bit different. So whatever stain you use in your laboratory, it's important that you become familiar with the staining pattern for these, because it varies from stain to stain. So you can see that the 3 pluses on the using the Oracle system, the Bond Oracle system, is strong positive, whereas the Hercept test, even in the 3 plus, is a little bit paler. So you've got to become familiar with what's your routine and have appropriate controls in place to do that. Antigen retrieval. So this is an unselective process. It affects all proteins, the target protein as well as non-target proteins. And it happens because of the cross-links that form between the antigens and the proteins from fixation. And sometimes that can mask the antibody's target site. So the immunohistochemical stain may not work. And we have lots of ways of doing antigen retrieval, using enzymatic processes or heat-related processes to release that those cross-links so that we can target those proteins once again. But over retrieval can be a problem because, as you can see here, this is a case which was HER2 negative on in situ hybridization. And with over retrieval, you can make negative stain positive. So it's important to recognize that. And you can see that the morphology of the section that's been over retrieved is somewhat looking a bit moth-eaten. So that's one way of picking up that you may have over retrieval, and also to look at your internal and external controls. So it's important to have a control on your slide, but I think most laboratories would have a control for negative and positive, but many laboratories don't have controls for for 1 pluses, and sometimes maybe not even 2 pluses. And what do we use? What's a validated control to use? I mean, I think that's a bit controversial. To find a case that's actually everybody agrees is 1 plus. And because of the heterogeneity, sometimes putting these controls on the slide can be difficult because you may not have positive staining in one area of the tumor. So I think it's important for us to try and find the right controls for all of the different stains. So there were zeros, the 1 plus, 2 plus, and 3 plus. So 4 separate controls on the cell on the slide is ideal if we can manage that. So the biggest part of the talk is really about how we interpret this and how we're actually going to report this going forward. And for us to be doing this in a more reliable and reproducible fashion. So if we come back to our original definitions of what is 0, 1 plus, 2 plus, and 3 plus, excuse me, you can see that in the 1 plus, what we're trying to do here is to perceive something that is said to be faint and barely perceptible membrane staining in 10% of the cells. You can see from the definition itself that is going to be problematic, that it is going to be difficult for us to be consistent. 10%, identifying 10% of something, we know as pathologists, is not the easiest thing. And then to perceive something that is faint or barely perceptible, again, represents another challenge. The 2 pluses and the 3 pluses and the zeros are relatively easy compared to that. Zeros and 3s, you scream hurrah when you see those on a slide because they're so easy. But the 1 pluses and the 2 pluses, we do equivocate over those. And I'm sure there's lots of inter-observer variation if we ask, our colleagues and fellow pathologists to review a slide, that whether it's a 1 plus or a 0 or a 1 plus or a 2 plus. So the HER2 low group, as I've mentioned, is that faint, barely perceptible staining, greater than 10%. I keep harping on the definition because though it sounds like something that's easy to define, it actually can be quite challenging. And I'm sure I'm having lots of nodding heads in the audience there. Identification of HER2 low cases is challenging, but it is so important given the efficacy of this drug space. And for many patients, this represents a targeted therapy that they wouldn't have had access to. It's probably one of the last lines of therapy that's actually going to be efficacious in these patients. So identifying these patients is really, really important. HER2 low itself is not a biological sub-cancer. It's not distinct, and I'll talk more about that in a second. We don't really have good reference standard or established controls for 1 plus. That is because the HER2 stain itself was developed and established to identify HER2 3 plus positivity. So the positive staining and the 3 plus staining was what we built the stain to look at in the first place. Now we are changing the way we look at this stain, and it's a new way of analyzing and reviewing these cases to go back and look for that 1 plus staining. In the past, zeros and 1 pluses, we could just negate those and call those negatives and get rid of them, push them off our desks. It's the 3 pluses that this whole immunohistochemical staining methodology was developed for. So now we really need to go back and reevaluate how we do this. And for the 2 pluses, we do have a second tier test available. We can go and test these, but that is not the case for the immunohistochemical stain for 1 plus. For 1 pluses, this is the standard. There's just immunohistochemistry, and we're reliant on using that to identify these patients. And the changes are really subtle. We need to ensure that we're looking very carefully for this staining. staining pattern can be very subtle. It can be only one side of the cell that is stained, or a U-shaped cellular staining. The staining can be very faint and imperceptible, as the definition suggests. And we need to go to high power, actually, to identify it. You can't do this at low magnification. You have to go to high power and scan the slide properly to identify it. We've recently undertaken in Australia a concordance study. And if you go to any of the breast cancer conferences around the world, like ASCO or San Antonio, there are lots of these studies floating around, and lots in the literature too, from the UK and the US. And they've really had pretty abysmal results in terms of identifying the HER2 low group, and very poor inter-observer variability and pathologist concordance. We've actually had really, really good results in Australia doing it. And we undertook a different methodology. So there were eight of us pathologists across Australia, and we basically had a training set. We sat down and multi-headed it all together to develop criteria to identify the HER2 low subgroup. And we came up with these rules. So with the training set, we came up with the rules, and then we validated it on subsequent sets. A total of 90 cases were reviewed. And in the end, we had a concordance level. When we used these staining criteria and these rules for staining, we had a kappa score of 0.81, which, as you would know, corresponds to excellent levels of concordance. This is one of the highest that we've seen in the literature. We haven't quite published this data yet, but it's in press. We have submitted it for publication. So our rules are that you should review all the tissue systematically. You should review all of the slide, all the tumor tissue at 40 times, but not to go beyond that. I know many people are using digital systems, so it's really easy to scroll beyond the 40 times, but it's best to stick at 40 times. And we look for only linear staining. Intercellular membrane staining is acceptable, but when the staining becomes granular or just luminal or just basal, then it's often an artifact. So we disregard those. So intercellular membrane or U-shaped staining around most of the cell is acceptable. If it's granular, or it's only luminal, or you have this sort of funny granular pattern of basal or luminal staining, we disregard that as artifactual staining. Of course, we disregard any nuclear or cytoplasmic staining or DCIS, and second opinions is always worthwhile doing. So we adopted this practical approach, and we start off, so we ask ourselves the answer is yes, then it's either a 3+ or a 2+. If it's incomplete membrane staining, then it's a 1+. If the staining is less than 10%, then we can assign it. And we also did use the ultra low and the null categories. These were much harder, and the variation was much harder in these cases, we found in our study, but we were quite successfully concordantly able to identify the 1+ using this drop-down algorithm, as well as the rules that I mentioned previously. One of the issues, of course, with HER2 expression is the heterogeneity that exists. And in the HER2 space, in the HER2 low space, this is even more problematic. HER2 is very heterogeneous, and immunohistochemistry is often better than in situ hybridization, because you can really visualize those positive clumps of cells and confirm it on your in situ hybridization. But in the HER2 low space, we don't really have clumps of cells like we do with the HER2 positive cases. It's often very mixed. So it's more like the D that we see here. So very intermixed cells. So you really have to go to high power and identify individual cells that are showing that incomplete, faint membranous staining that is linear, not granular, but linear in its features. Intercellular or U-shaped staining, if it's only at the base or at the lumen, then we tend to disregard those. And there are gaps in the current definitions of HER2. Like, what do we call it if there is weak or moderate membrane staining in less than 10%, or strong but incomplete membrane staining in greater than 10%, or barely perceptible staining that is, in the vast majority of the slide? So there are some some discrepancies from the current definitions that exist for HER2 testing. But what we try to remember and apply is weak or barely perceptible partial membrane staining when we're looking for a 10% cutoff in invasive carcinoma cells. So here is an example. You can see here that the staining is predominantly, the dark staining that you see is at the basal part of the cells. And you can see it's kind of variable in thickness. So there are some thick lines and some thin lines. So this staining I would disregard, the basal staining, and you would only count the intercellular staining or the C-shaped or the U-shaped stain that you see. The thick part at the basal aspects of the cell is probably artifactual staining. Here, we've got a lot of cytoplasmic staining. We've got to be able to subtract that and discount that and only look at the linear membrane staining that you can see between the tumor cells. And it's got to be sort of an even line, linear staining. No granular patterns should be acceptable. And what about this case? Here you can see the internal control. We've got a lot of staining of the benign ducts. Should we repeat this stain? Is it reliable? Can we rely on it? I would suggest that we probably need to repeat it and look at our controls carefully. So as I mentioned before, the HER2 low group itself, there's been several studies now in the literature that have looked at the molecular subtype and looked at it at a genetic level. They're not actually a distinct pathological subtype. It's actually a basket full of different types of tumors. And we have in there ER positive and ER negative tumors. In fact, they tend to be mostly luminal type of tumors. And the only sort of common feature that we can see is that HER2 low is a biomarker for benefit from antibody drug conjugates and not actually a distinct biological subtype in itself. You can see this study looked at mRNA levels, and you can see there is a stepwise progression from 0 to 1+ to 2+ to 3+ of the mRNA in line with the immunohistochemical stains. But even then, we can't use mRNA instead of using immunohistochemistry because there is a lot of overlap between those mRNA expression levels. So that's not going to help us give us a more quantitative result for the HER2 low group. And importantly, HER2 status is dynamic. So this may be a reflection of tumor heterogeneity or selection pressure from previous therapeutic agents, or it could be due to testing inaccuracies in older archival samples. But it is very frequent. You can see that it goes most frequently from HER2, the HER2 low and HER2 zero groups are the most labile. So this is important because it means that when you're testing in the metastatic space, you can test any sample. So all the clinical trials actually you could use any sample, the primary, any metastatic sites, but bone sites are the ones that are difficult. They did not include these because of the decalcification process. But this is important to note. So you can test any of the patient samples to find one positive sample, and these patients will respond to the therapy. So finally, just to finish up, there has been even further evolution of this HER2 paradigm, the HER2 story that we're talking about here. And very recently, so there's been a lot of excitement about the DESTINY-Breast06 trial, which is a phase 3 trial that investigated T-DXd versus taxanes or capecitabine, Xeloda, in patients with metastatic ER-positive breast cancer who progressed on endocrine therapy but had no prior chemotherapy or anti-HER2 therapy for their metastatic disease. So this is really important area for expanded use of these antibody drug conjugates for that ER-positive group. It is really a group in need of something, those patients that progress on endocrine therapy. It included those patients that had HER2 low as well as HER2 ultra low, and I'll come to the definition of that in a moment. And this is different from DB04, in which 10% of patients were actually triple negative, and they didn't include the ultra low group. So these is ER positive patients, right? Now, these patients had to be ER positive. HER2 could be positive, but we didn't include triple negatives in this group. And that's a really important group, is the ER positive group, that luminal breast cancers that progress on endocrine therapy. And it really does represent a potential for expanded use of T-DXd in this first-line metastatic failure, endocrine therapy failure setting, and which a lot of patients do fall into in our service anyway. So now we have a very complex algorithm here. We've gone from the positive negative to now having, 6 subgroups. The HER2 null, where there's no expression of antibody, to the ultra low, and the HER2 low group, which is 2+ positive, but ish negative, or HER2 1+. And the ultra low is, less than 10% of weakly perceptible staining. So any level of expression of this protein in this with very faint or imperceptible immunohistochemical staining fall into that group of the ultra low. So it's really become very complex from where we were with our positive and negative group to this much more refined and much more granular view. So the HER2 ultra low group is those patients with incomplete membrane staining that is, again, faint or barely perceptible, but in more than 10% of cells. I think in the study they used a 1% cutoff. So those with less than 1% are called the HER2 null group. So more and more in our pathology reports, we are including all of these details. We used to previously call things that were 0 or 1+ just HER2 negative, and we put 0 or 1+. Now we really have to probably state exactly the percentage of cells that's staining and the intensity of staining, and even give it a name, whether it's HER2 low, HER2 ultra low, or HER2 negative in our pathology reports. So just to finish up, so there really has been a paradigm shift in the way that we report HER2, and it's continuing to evolve. It could be that we find that we don't even need to do HER2 testing, that all patients will respond to TDXD, who knows? But the ultra-low group is emerging as another group, yet another group that we have to add to our pathology reports for these patients. And it's really important for these patients who are ER positive and failed on their anti-endocrine therapy. It's a large group of patients, so potential to benefit a huge number of patients there. And really, the current HER2 assays were developed to pick up HER2 expression at a much higher dynamic range. And now we are looking at it at the lowest end of the spectrum to pick up any faint staining at all in that, especially in that ultra low space. So we really need to develop some rules and ways that we're going to do this and do it in an accurate and reproducible manner. And as I mentioned, we have to take into account very careful reassessment of the pre-analytic and analytic processes to take into account this low-end range of the spectrum. So things like putting in new controls, additional controls, sitting together with your colleagues and coming up with some rules for scoring and putting together some test sets so that we're doing this in a more reproducible manner. I think we need to have education programs and QAP programs that cover all aspects of testing, including this low end of the spectrum. I think that digital platforms will provide us with an opportunity for greater reproducibility. And this is a paper from Peter McCallum and some colleagues and friends of mine from that organization that are looking at digital testing. And what they found, first of all, importantly for us as pathologists, that the manual methods took much longer than the digital methods, so you could really speed up your reporting time using this digital methodology. So this used something called UPath, which is a digital algorithm that's developed specially for HER2 testing. And it actually, you can see, it quantitates the numbers, copy numbers, using a digital algorithm. And this is found to be highly reproducible and very accurate, speeding up time. And especially for those cases with equivocal and low numbers of HER2 copies, it's been found to be really helpful. And I think going forward, this might be a tool that we might all turn to help us with our reporting of HER2 cases. So with that, I'll finish, and I'm happy to take any questions.
Thank you, Dr. Nirmala, for a very enlightening talk yet again. Thank you so much. It was lovely listening to you. So there are a couple of questions in the chat box.
Yep.
Yeah. So one question says, can anti-HER2 therapy be used in non-breast cancer if there are HER2 positive?
Yes, definitely. Anti-HER2 therapies have been looked at. It's not my area of expertise, but the answer to that is yes. I'm not familiar with the clinical trials and efficacy, but the answer to that is probably a yes. There are anti-HER2 therapies used in gastric carcinoma, obviously, for example. But I don't know about in the HER2 low expressing state. I don't know what trials there are out there. Not my area of expertise, sorry.
Okay, sure. Thanks. So there is another question which says that what is your opinion on manual testing versus automated? Manual testing reports are equally good as compared to automated.
Look, it's what you can get your hands on, isn't it? I mean, if you don't have access to automated testing, then of course manual testing can be done very well. And you can do it if you have a reliable lab processes, it can be done very well. But the advantage of automated is that you're going to have much more reliability and reproducibility and the ability to do multiple stains at the one time. So there is an advantage to automation, and definitely you're going to have better reproducibility. But if you don't have access to it, I'm sure that you can, optimize your laboratory processes to make sure that things are being done in a very controlled fashion.
Sure. Okay. Then there is another question. Once diagnosed as HER2 3+, do we need to consider the tumor as HER2 positive always, even if the expression is lost in the subsequent biopsies? Like in the
Go on.
Like in the adjuvant setting, post-neoadjuvant chemotherapy plus anti-HER therapy. We continue with the anti-HER2 therapy in this setting, even if HER2 new comes negative. Does the same thing applicable in metastatic setting also?
That is a really good question. And the answer to that is probably yes. Once they've been diagnosed with HER2 positivity, in practice, that's how we work here. We continue to administer anti-HER2 therapies for these patients and consider them HER2 positive. As I said, the receptor status is labile, and in the metastatic state, you may have treatment selection pressure or heterogeneity, where you have a clone of cells that have escaped and are not HER2 positive. But that is also to say that maybe there are, microscopic clones or, circulating tumor cells that still do express HER2. So if you start off as HER2 positive, you continue to think of that patient as a HER2 positive patient.
Another interesting question it asks that we need to move away from HER2 IHC and ISH testing to HER2 RNA assay. What are your comments?
Well, yes, look, this comes up all the time, and it would be lovely to have a quantitated way of assessing HER2. But the reality is that all of the clinical trials that have been developed on the basis of immunohistochemistry. So finding those HER2 low positive group using immunohistochemistry was the definition of the HER2 low group for the clinical trials, and the drug was efficacious in those patients defined using immunohistochemistry. Therefore, we are bound to stick to that. We can't find another way unless we, unless we can go back and retest those samples using RNA and find a more accurate way of doing it. For the time being, we are stuck with immunohistochemistry, and this is the way the patients have been defined in the group that did respond to therapy, and therefore we must continue to use that same methodology that was outlined in those clinical trials.
Sure. So there is a lot of appreciation also flowing in. Very informative talk, eye-opening talk, excellent presentation. Then there are a few questions on the ultra low as well, that are there any guidelines to identify HER2 ultra low cases? And when it comes to reporting, how would it be reporting as an IHC score?
Yes. Well, look, there are no set guidelines that have been developed for the ultra low group yet. This is very new. It is very hot off the press. So we're using those ASCO CAP guidelines, and yes, you're right to use those in your actual reports yet. I certainly am not putting them into my reports yet. I think it's important that we're aware of it, and if we're asked by our medical oncology colleagues, be able to provide them with the result. But some of the labs here in Australia, I've noticed, have started to call it, HER2 negative or HER2 low and HER2 ultra low. So they are using that terminology in their reports. I don't think we're quite there yet. I think we're not ready for mainstream reporting and putting these into our reports just yet. I think we need to stick to our actual percentages, intensities, and put the detail into the report, but don't actually put a bottom line in terms of classifying it as HER2 low, HER2 ultra low, because that could still be misinterpreted. In my view, I think if you put something as HER2 low, that could also mean low level amplification, and you give the patient anti-HER2 therapies, your traditional anti-HER2 therapies. So I think we're not quite there yet. This is not ready for mainstream, but I do encourage everybody to put into their reports the actual percentages and intensity of staining. And then, do use the 0, 1 plus, 2 plus, 3 plus, but I wouldn't use the ultra low and low terminology just yet. That is my personal view anyway.
All right, thanks. Then there are a couple of questions on DISH, that can DISH differentiate HER2 gene amplification from polysomy? And is DISH cost effective when compared to FISH?
Yes, the answer to the last part is yes. Once you've got if you've got an automated system, yes, it's more economical than FISH testing. You don't need to have a separate microscopy, dark field microscopy set up for DISH testing. You can just use your bright field microscope. You can put it on your automated Ventana to do the tests overnight. So all of those things, it's a lot less labor intensive. And then polysome, the question on polysomy, yes. So you can visualize the chromosome 17 and the HER2 signals on the slide simultaneously. So the polysomy you can pick up through the red signals, which are the chromosome 17. So you can diagnose, concurrent polysomy and amplifications, which can co-occur, of course. And then we have a set of rules, if you look at the ASCO-CAP guidelines, as to how we interpret those. So if you have you have to interpret those in concert with immunohistochemistry. So if you've got polysomy as well as gene amplification and your ratio is less than 2, but you've got a positive 3 plus positive on immunohistochemistry, we call those cases, for example, positive. So you've got to use both immunohistochemistry and ISH testing for those equivocal cases. But the answer is yes, you can distinguish polysomy using your Silver Insight, your DISH testing, yes.
So are there chances that DDISH will replace FISH completely?
It has in Australia.
Okay.
We very rarely use FISH at all. So as I mentioned, most laboratories, and it's actually recommended by our colleges to use DISH, bright field microscopy testing, and FISH is reserved really for those cases where you have very low levels of amplification or very equivocal ratios. We sometimes will turn to FISH for those because you can enumerate the signals much more clearly with the high magnification that you see in the fluorescent signals. But in Australia, we only use bright field techniques such as DISH, and it's completely replaced FISH altogether. Yes.
Yeah.
It's easier. It's automated. You use bright field microscopy. So yeah, definitely it's a much easier technique than FISH, which really needs a lot of specialized equipment.
Right. So just a couple of last few questions. I mean, there are a lot of questions flowing in, but I'm cognizant of the time as well.
No, I'm good. Yeah. Go, keep going.
So there is another question on antigen retrieval. How can we control antigen retrieval to prevent overdiagnosis?
Yeah, well, that is basically through using your controls and following your laboratory protocols. So there are good protocols written for the various antibodies to follow those to the letter and to use your controls to check. It's really by looking at your controls that you can know whether you've got over-retrieval or not.
And I think this you mostly answered in your last slide, that can we rely completely on digital or computational pathology? I mean, is it 100% reliable?
No. I have played around a lot with digital algorithms now. They still need to be checked by the pathologist. The pathologist still needs to go through. And so even that UPath algorithm, that it really helps. It speeds it up very quick. It makes it very quick because counting the individual signals takes a lot of time. Sometimes you can spend half an hour on one slide if you've got equivocal numbers, counting multiple areas of 20 cells. This has a way of identifying the areas with the highest expression. So it gives you a heat map. And then it also does the counting for you. But you do need to verify it. A pathologist will always need to verify it. So digital algorithms are there, and they're going to be fantastic in making things easier and faster for us. But we are always going to need to still put our eyes on that and double check it to make sure that it's identifying tumor cells as tumor cells and counting the appropriate signals.
Okay. So I don't know whether I am getting this question right or not. Do we know the cognate ligand for HER2 or other HER members other than EGFR? It seems to
I
be.
think it's asking about the other HER2 family.
Correct.
Yeah. So look, the HER2 receptor itself is the one that's been best understood. There may be effectivity of the HER2 and the HER3 receptors, but that hasn't been understood or studied as well as the HER2 receptor. There is most likely to be some mechanisms that can impact the HER2/3 receptors and other EGFR receptors, but we don't understand those mechanisms as well as we do. It's very complex, obviously, but we don't understand those mechanisms as well as we do the HER2 receptor itself.
Sure. And then there is one last question asking about your practice on doing the reflex ISH. Do you do it for 1+ or 2+ cases or only for IHC 2+?
Yeah,
Reflex
so now
to ISH.
Yeah, so the guidance that we most recently been given in Australia by our college is that we only reflex test the 2+ and the 3+. So the 0s and the 1s do not need ISH testing. We used to test all cases routinely, but we have stopped doing that in the last 5 or so years. We only do the 2+ and the 3+.
3+ are also going for ISH?
Yes, that is because in Australia, the ISH test is needed. A positive ISH test is required to get access through our pharmaceutical benefit schemes to these anti-HER2 therapies, because ISH tests are in many ways more reliable than immunohistochemistry, because DNA, as I mentioned, is more robust than proteins on the cell membrane. So they're much more reliable, even if you have fixation issues, that it'll still work.
Okay, fine. And just to close this, in your opinion, do you think ASCO-CAP will, recommend to use the HER2-low terminology? Is there a guideline update expected?
I think there will have to be a guideline update expected, and from the sources that I know that are involved, this will have to come into play once there is more maturation of the data. But at least in the HER2 low, the 1+ space, there is definitely it's been spoken about at all the international conferences that I've been to. The breast pathologists are looking at how to write criteria, and there will definitely be an update on this going forward for sure. And even in the ultra low space, I know it's early days yet, but once that data comes and it matures, I think there will definitely be updates to the ASCO-CAP guidelines. So it's important for us to keep aware of it. But also, if our clinical colleagues ask us to do this, we really need to come together as a team, and rather than waiting for this to mature, we need to be thinking about it ahead of time and getting ready to report it accurately, reproducibly, and know about it. So our oncologists come up to us and say, do you know about this? Is this patient HER2 low? We need to be able to give them an answer and be able to produce an accurate, reliable, reproducible result, and that work with our colleagues to have some QA processes around that.
Okay. Thank you. Thank you again, Dr. Nirmala. Thank you so much for your patience, patiently answering all the questions.
Not at all. My pleasure.
I'll just hand it over to Dr. Geeta to give the final vote of thanks.
Hello, Dr. Nirmala. It was an excellent talk, very informative, very useful. So I have just 1 or 2 questions. The first one was, how do you report DISH? Do you use the image analysis and a 60x, or you do it manually under the microscope?
We do it manually under the microscope. We're not using a digital algorithm yet, because that actually doesn't have approval to be used just yet, not in Australia. So we do it manually. So I do an individual cell count, and it is a bit of a laborious process counting up the cells, but yeah, I'm doing it using just a light microscope, and we report the number of signals of the HER2 gene, of the chromosome 17 gene, and a ratio is how we report it. And then we have, I showed a slide earlier which looked at the different, there are 6 different reporting categories. So we put them into one of those categories, whether it's HER2 positive, HER2 equivocal, HER2 polysomy, and there are a few different categories. I don't know if you guys have seen that. They're in the ASCO-CAP guidelines.
And you use 40x or 60x?
Yes,
40.
no, I use 40. I
Okay.
don't find it that much more. I have tried 60. I don't find it that much more helpful, to be honest.
Okay.
Yeah.
But we had tried, but it's sort of a little strenuous, I felt, looking at 40.
It is
I mean,
strenuous.
it is strenuous. Okay.
Yes. So one little trick you can do is take a digital image and
Yes.
count it that way, but it's not
Yeah.
as good. You don't get as good resolution. It is strenuous
Okay.
on the eyes. I find it really difficult. I can't wait for the algorithms, the digital algorithms, to come and take over, because then it's
Okay.
very quick. You can actually just look at the screen and it shows you the cells with the amplification. If there's heterogeneity, it picks it up. It really makes life a lot easier. I hate counting those signals. It's very laborious.
Yeah. The second question was, you said you were doing ISH for all IHC 3+ cases.
Yes.
So what was your level of discrepancy between IHC and ISH on these cases?
Yeah, well, in
because
the early
we are
days,
not doing, and are we missing something by not doing? That's what I wanted.
Look, that's a really good question, but you're doing what the rest of the world does. In Australasia, because everything is funded by the government, they're really strict to make sure that they're not, over-diagnosing HER2 positivity. So we use the ISH because it's more reliable. But now our immunohistochemical processes, because of automation and use of controlled and quality assurance programs, we have very high degree of concordance. So I don't think you guys are missing anything. Yeah.
Okay. So only when there's a borderline between 2 and 3, all those we ask for ISH. But 100%, we are 100% definite it's 3+. Then we don't.
Then you just call it 3+.
Yeah.
That's what the rest of the world does, Dr. Mukherjee.
Okay.
That's what they all do. Yeah.
Okay. So I think we can end the program. On behalf of MPAI, I thank Dr. Nirmala Padmanabhan for having spent a lot of time and having cut her sleep, because you said it's late night now, and to enlighten us on the latest advances in HER2 testing and scoring methods. Thank you very much, Dr. Nirmala. It was excellent. I'm just going
to say thank you so much. And don't worry, you can only see the top half. I've got my pajamas on underneath.
So I also thank all the participants for attending and actively participating in the webinar.
Yes.
And I thank AstraZeneca, Dr. Ms. Bhavana, and everyone else for sponsoring the session. Thank you very much.
Thank you all very much.
Good night.
Good
Thanks,
night.
Dr. Nirmala.
Good night.
Bye-bye.
Thank you.
Bye.